Good morning, everyone. Today's topic for case presentation is Epistaxis, presented by myself, Dr. Manan Balara, under the guidance of Dr. Tarun Oja, sir. So, my patient is Mohan, who is 10 years male, Hindu by religion, from Sitapura, Jaipur, currently a student belonging to middle socioeconomic class. The importance of name in my case is that it is useful for the identification of the patient, for developing rapport with the patient, for maintaining the record of the patient, and it may help in identifying the unknown religion. Importance of age in my case is that in young people, nasopharyngeal angiofibroma, rhinosporidiosis, and atrophic rhinitis is more common, and in elderly, carcinoma of maxilla is more common. Relevance of sex in my case is that nasopharyngeal angiofibroma occurs exclusively in males, and rhinosporidiosis is more common in males. In females, atrophic rhinitis is more common, with the ratio accounting for 1 is to 5.6. The importance of address in my case is that rhinosporidiosis is very common in Jharkhand, Chhattisgarh, Madhya Pradesh, and West Bengal. Atrophic rhinitis is more common in tropical countries like India. Rhinoscleroma is more common in northern states of India, and Plummer-Wilson is common in central part of Gujarat. The importance of occupation in my case is that in farmers, rhinosporidiosis is more common. Vasomotor rhinitis is more common in dusty environment, and similarly in nickel, chromium, and arsenic workers, septal perforation is more common. Importance of caste in my case is that in Bodhya community of Vidarbha region of India has more incidence of sickle cell anemia. Hence, episodes of epistaxis are more common. Sindhis and Bhanushalis of region have more incidence of thalassemia major and have more episodes of epistaxis and bleeding disorder. So this is the modified Kupuswamy classification that covers three aspects: education of the head of the family, occupation of the head of the family, and total per capita family income per month. So education of the head of the family, it covers the following points. If the person has professional degree, the score is 7. If he's a graduate, 6. If he's a diploma, the score is 5. If he's going to high school, 4. If in middle school, 3, primary school, 2, and if the person is illiterate, the score is 1. Similarly, the occupation of the head of the family covers: if the person is professional, the score is 10. If he is semi-professional, score is 6. If he is clerical, shop or farmer, the score is 5. If he is skilled worker, 4. And semi-skilled worker is 3. Unskilled worker accounts for 2. And unemployed person has a score of 1. And in terms of total per capita family income, if the person is earning 2000 above, the score is 12. If the score is between 1000 to 2000, the score is 10. And if the income is 750 to 999, the score is 6. If the income is 500 to 749, the score is 4. If the income is from 300 to 500, the score is 3. And if the income is 101 to 299, the score is 2. And if the income is less than 100, the score is 1. On adding up the score, if the total score is between 26 to 29, the socioeconomic class is upper class. If the score is between 16 to 25, the class is upper middle. If the score is between 11 to 15, the score is lower middle. If the score is between 5 to 10, the socioeconomic class is upper lower. And if the score is below 5, socioeconomic class is lower. So my patient came to the chief complaint of bleeding from the nose since 1 year. So history of presenting illness. As told by patient's mother, the patient had bleeding from the nose since 1 year. Bleeding was insidious in onset. Frank epistaxis was present, intermittent in nature, that is 1 episode per week, not mixed with any type of discharge, not any type of nasal obstruction. It stops spontaneously and is relieved after taking medications and applying pressure and with no aggravating factors. Patient had a habit of picking of nose. The causes of epistaxis could be covered under local causes, which could be covered under following headings like trauma due to fingernail trauma, injuries to the nose, accidental surgery, nasal intubation, head injuries, foreign bodies, or rhinolith. Infections could be due to like rhinitis, sinusitis, adenoiditis, diphtheria, granulomatous lesions, or atrophic rhinitis, etc. And in neoplasms, it could be covered under benign and malignant headings: benign lesions like hemangioma, inverted papilloma, juvenile angiofibroma, and aneurysms. And for malignant neoplasms, it could be due to epidermal carcinoma, adenocarcinoma, and sarcoma. In environmental causes could be like high altitude, sudden decompression, and chemicals carcinoma. And drugs usage could be like nasal sprays and drops of antihistaminics and steroids or sniffing of cocaine and snuffs. And miscellaneous causes could be like septal deformities and perforation. The general causes of epistaxis could be covered under following headings like cardiovascular causes like hypertension, mitral stenosis, congestive heart failure, or eclampsia of pregnancy. Hemopoietic causes like aplastic anemia, leukemia, and thrombocytopenic purpura or hemophilia. Nutritional causes like malnutrition, scurvy, alcohol abuse, vitamin A, D, E, and K deficiencies, or blood vessels like arteriosclerosis or collagen diseases. Liver diseases like hepatic cirrhosis due to deficiency of factor 2, 7, 9, and 10, or kidney disease like chronic nephritis and renal failure, or the use of drugs like aspirin and NSAIDs, and acute infections like influenza, measles, chickenpox, whooping cough, rheumatic fever, typhoid, pneumonia, or dengue. So the blood supply of nose is from internal carotid artery and external carotid artery. So the internal carotid artery branches are anterior and the posterior ethmoidal artery, which are both the branches of ophthalmic artery. In the external carotid artery system, it is the branches are following the sphenopalatine artery and septal branch of greater palatine artery, which are both the branches of maxillary artery, and the septal branch of superior labial artery, which is the branch of facial artery. So this is the diagrammatic representation of blood supply of nasal septum, as can be seen. And this is the blood supply of lateral wall of nose. So the sites of epistaxis, the most common site is Little's area. It is situated in anterior inferior part of nasal cavity and is supplied by branches of both internal and the external carotid arteries. The four arteries, the branches of which form the plexus, that is the Kisselback plexus, in this region are anterior ethmoidal branch of ophthalmic artery, septal branch of superior labial branch of facial artery, septal branch of sphenopalatine branch of maxillary artery, and greater palatine branch of maxillary artery. It could be above the middle turbinate where the area is supplied by anterior and posterior ethmoidal branches of ophthalmic artery, or below middle turbinate where the area is supplied by sphenopalatine branch of internal maxillary artery. And it could be due to Woodruff's plexus, which is the venous plexus situated inferior to posterior end of inferior turbinate, and it is the most common site for posterior epistaxis in adults. At the site of epistaxis could be retrocolumnar veins that turns vertically downwards just behind columnella, crosses nasal floor, and joins venous plexus of lateral wall. It's a common site for epistaxis in young patients. And diffuse epistaxis is present from septum and lateral wall. So the difference between anterior and posterior epistaxis, that is, the anterior nasal bleeding is more common as compared to posterior. The common sites for anterior nasal bleeding are Little's area, whereas the posterior nasal bleeding is more common in posterior superior part of nasal cavity. Localization is easy in terms of anterior nasal bleeding, and it is difficult in posterior nasal bleeding. Anterior nasal bleeding is more common in children and young people, while elderly people suffer more from posterior epistaxis. The common causes for anterior could be due to trauma or frequent picking of due to fingernail trauma or frequent picking of nose, and in posterior it could be due to arteriosclerosis and hypertension. Nasal endoscopy is generally not required in terms of anterior, but it is required in posterior. So severity, anterior nasal bleeding is a mild bleeding, but posterior nasal bleeding most commonly presents as profuse bleeding. And management of anterior is comparatively easy, and it is used in OPD. And posterior nasal bleeding management is difficult, and it is managed in operation theater. So negative history. So my patient has no history of nasal obstruction, no history of pain in the nose. There is no history of fever. There is no history of loss of body weight. There is no history of headache, lacrimation, or itching in nose. No history of disturbed smell. No history of chronic use of nasal spray, and no history of denasal speech. Importance of negative history in my case is that history of recurrent epistaxis associated with unilateral nasal obstruction, denasal speech in the age group of 10 to 25 years of age could be pointing towards juvenile nasopharyngeal angiofibroma, which in my case, it is not associated with any of the above features. And history of epistaxis with cervical lymphadenopathy could be pointing towards nasopharyngeal carcinoma. So past history. My patient had a normal history of normal vaginal delivery, normal institutional vaginal delivery. There is no history of bleeding disorder or asthma. There is no history of blood transfusion in past. There is no history of hypertension or diabetes mellitus or allergy to dust and smoke. There is no history of blood transfusion in past or drug allergy or surgery in the past. My patient is vegetarian. Appetite is normal. Bowel and bladder habits are found to be normal and the sleep is adequate. No significant family history is present in my case, and immunization history is my patient is completely immunized as told by the mother. Importance of past history. History of evening rise on temperature and loss of weight, appetite could be pointing towards tuberculosis of nose, that could be nodular, ulcerative, or lupus vulgaris. History of blood pressure. In my case, is important that blood pressure could be associated with epistaxis, and it is a relative contraindication to surgery. Diabetes mellitus could be pointing towards fungal infection of nose. Asthma could be associated with nasal allergy, and allergy could be associated with various causes like allergic rhinitis, vasomotor rhinitis, ethmoidal polyp, and asthma. And there is history of any medical and surgical treatment in the past is important. And similarly, the history of vaginal delivery is important that it could be associated with trauma at the time of birth. Importance of personal history is that history of excessive use of nasal decongestants, hypotensive drugs could be pointing towards rhinitis medicamentosa or chronic nasal obstruction. And importance of family history is that history of similar complaints in the family could be pointing towards epistaxis, and history of bleeding disorders, hypertension, diabetes mellitus are associated with family history. So general examination. My patient is calm, conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built and nourished. Pallor is present and no icterus, clubbing, cyanosis, generalized lymphadenopathy, or pedal edema is seen. Vitals. So my patient vitals are the BP is 100/70 in right brachial artery in sitting position. Pulse is 90 per minute. Regular in rhythm, rate, and volume in right radial artery. Respiratory rate is 20 per minute, abdominothoracic type, and temperature, the patient is afebrile on touch. Systemic examination, the cardiovascular system, in the first and second heart sound are present and no murmur is heard. In respiratory system, vesicular breathing is present, bilateral air entry was found to be equal, and no additional sounds were heard. In central nervous system, higher mental functions were found to be normal, and in per abdomen the findings were it was soft, non-tender, no guarding, and no rigidity, and no organomegaly was seen. Significance of general examination is that general examination is done for proper diagnosis and differential diagnosis, for selecting the patient for anesthesia, to decide the type of surgery to be done, and to predict the prognosis. The mental status and level of consciousness should be assessed in general, but in specific clinical situations like head injury, hepatic encephalopathy, and septic shock, it is important. Now, coming to Glasgow Coma Scale. In Glasgow Coma Scale, 3 headings are covered, that is the eye-opening response, the verbal response, and the motor response. In eye-opening response, we see the following parameters: whether it opens spontaneously, it opens to verbal command, speech, or shout, and if the eyes open to pain, or there is no eye opening. And similarly, the scoring is 4 for spontaneous and 3 for opening to verbal command. If the open to pain, the score is 2, and if there is no eye opening, the score is 1. In terms of verbal response, we cover oriented, and it is awarded a score of 5. If the patient is confused, conversation, but is able to answer questions, the score is 4. If inappropriate responses and words discernible is seen, the score is 3. And incomprehensible sound or speech is present, the score is 2. And if there is no verbal response, the score is 1. In terms of motor response, we cover the following headings. If the patient obeys commands for movement, the score is 6. If the purposeful movement to painful stimulus is present, the score is 5. If the patient withdraws from pain, the score is 4. If the abnormal flexion or decorticate posture is present, the score is 3. And if the extensor response is seen and decerebrate posture is seen, the score is 2. And if there is no motor response, the score is 1. So in terms of minor brain injury, the score is between 13 to 15. In terms of moderate brain injury, the score is between 9 to 12. And in severe brain injury, the score is between 3 to 8. So in for scoring, we add up the responses from eye opening, verbal response, and motor response. It is added, and the maximum score that can be seen is 15, and the minimum score is 3. So GC Glasgow Coma Scale in intubated patient is that patients who are intubated are unable to speak and their verbal score cannot be accessed. They are evaluated only based on eye opening and motor scores, and the suffix T is added to their score to indicate intubation. In intubated patients, the maximum GHCS score is 10T and the minimum score is 2T. Now coming to built and nutritional status. So built is structural organization of underlying skeleton. It is related to age and sex of the patient. A person is said to be malnourished if BMI is less than 18.5 or the patient has lost more than 5% of body weight during the last 3 to 6 months. Infants are said to be malnourished if weight for height is below 3 standard deviation, visible severe muscle wasting and presence of bipedal edema according to WHO classification. So nutrition is the proportion of soft tissue structures like muscles, soft tissues or fat in relation to the bony structure. Protein deficiency causes rough skin, brittle hair and edema of the feet. Fat deficiency causes cachexia, hollow cheeks and loss of fat in hips, abdomen and subcutaneous tissue of elbow. Now coming to pallor. So pallor is paleness of skin and mucous membrane either as a result of diminished circulating red blood cells or diminished blood supply. So pallor is usually checked in lower palpebral conjunctiva, mucous membrane of the lips and the cheek, nail beds, and palmar creases. So causes of pallor are epistaxis, massive bleeding, shock, throat carcinomas, nasopharyngeal angiofibroma, or iron deficiency anemia, which could be associated with Plummer-Vinson syndrome or atrophic rhinitis. Icterus. It is due to deposition of bile pigments with excess of it in plasma. It is checked in upper sclera, better seen against white background by asking the patient to look at his feet and clinician pulls the upper eyelid upwards. It can also be checked in nail bed, ear lobule, nasal tip or under the surface of tongue. Now coming to cyanosis, it is due to rise in level of reduced hemoglobin in the blood causing blue or purple discoloration in the skin and mucous membrane. A minimum of 5 gram per deciliter of reduced hemoglobin should be present in the circulation to cause cyanosis. Peripheral cyanosis is checked in nail bed, palms and toes, tip of the nose. Tongue is not involved in peripheral cyanosis. Central cyanosis is usually confirmed by checking in tongue, nail bed, palms and the toes. Cyanosis is seen in foreign body bronchus with lung collapse, and cyanosis is also seen in obstructive sleep apnea and choanal atresia. Now edema. It is the collection of the fluid in the interstitial spaces of soft tissue. Edema will be clinically evident only when fluid accumulates more than 5 liters. Pitting on pressure is the cardinal sign of edema. Conditions in ENT with edema are seen in mixed edema, angioneurotic edema, cachexia in malignancy, or liver metastatic carcinoma, or metastatic lymph nodes pressing on lymphatics. Now pulse. So normal pulse rate is 60 to 100 per minute. 5 characters of pulse to be examined are rate, rhythm, volume, character, radio-radial delay, and peripheral pulses. Tachycardia is increased pulse rate that is more than 100 per minute as seen in pharyngitis, tonsillitis, fever, sepsis, or severe pain. Bradycardia is decreased pulse rate that is less than 60 per minute. The person is said to be in hypertension if he has persistent raised systolic above 140 mm Hg or diastolic above 90 mm Hg of BP. It is sustained elevation of systemic arterial pressure. It is seen in thyrotoxicosis and raised intracranial tension. Hypotension is diminished blood pressure, that is systolic blood pressure less than 90 mm of Hg and diastolic pressure is less than 60 mm Hg. It is seen in cachexia of malignancy, tuberculosis, anemia, or due to functional causes. Respiration. A person is said to be in tachypnea when the respiratory rate is greater than 20 per minute and it is seen in hypo or hyperthyroidism, metastasis, fever, shock, hypoxia, acidosis, tetany, or hysteria. Gradual deepening of respiration alternating with short periods of apnea is called as giant stroke respiration. Now fever or rise in temperature. So normal temperature is 36.7 to 37.5 degrees Celsius. A diurnal variation of 1 degree Celsius is normal. Lowest temperature is seen during morning, that is between 2 to 4 am, and highest being in afternoon. Fever is increase in body temperature more than 1 degree Celsius or more than the maximum range. and it could be checked in oral, axillary, or rectal sites. So types of fever. Continuous fever, remittent fever, and intermittent fever are the various types of fever. So continuous fever is the one when the fever is present throughout the day and does not fluctuate more than 1 degree Celsius in 24 hours. Remittent fever is one that is fever is above normal throughout the day, but there is fluctuation of more than 1 degree Celsius in 24 hours. And intermittent fever, the temperature is present only for few hours a day and reaches to normal. When fever develops daily, it is called as quotidian, and when fever develops on alternate days, it is called as tertian, and when it occurs every third day, it is called as quartan. On local examination of nose, the patient's skin over nose was found to be normal. No external deformities were seen. On anterior rhinoscopy, mucosal abrasion was present at anterior one-third of nasal septum, and on left side it was found to be normal. And the nasal mucosa was found to be normal, pinkish on both right and the left side. Similarly, nasal floor, cavity, inferior turbinate, and inferior meatus were all found to be normal on both right and the left side, and middle turbinate and meatus was not visualized. On posterior rhinoscopy, posterior part of nasal septum, both choana, roof, and posterior wall of nasopharynx, opening of eustachian tube on both sides, and fossa of Rosenmüller on both sides was found to be normal. Bilateral PNS tenderness was not present. On Coe's spatula test, cotton wool test, and Cottle test were all found to be normal. So differential diagnosis of external examination of the nose could be that depressed nasal bridge could be seen in leprosy, syphilis, or tuberculosis. Nasal injury is common after RTA. Deviated nose is common in boxers. Congenital swelling is seen in glioma. Benign condition is more associated with rhinophima, that is potato nose. Broadening of the nose is seen in atrochoanal polyp. Frog face deformity is seen in JNA. Crepitus is seen in fracture of the nasal bone. Acne rosacea is a typical butterfly rash over nose and the cheek. Dermoid cyst is seen as a discharging sinus at the cartilaginous junction of the nose. And furuncle present as a tender red swelling at the tip of the nose. Enlargement of bony skeleton is seen in Pagets disease or fibro-osseous disease. Cartilaginous enlargement is seen in chondroma or chondrosarcoma. Ulcer or neoplasm could be associated with basal cell carcinoma, squamous cell carcinoma, herpes zoster or simplex, and woody field is associated with rhinoscleroma. So differential diagnosis of anterior rhinoscopy. In terms of nasal septum, mucosal abrasion is seen in case of epistaxis, or it could be associated with septal spur, deviation, dislocation, or perforation as seen in syphilis, tuberculosis, granulomatous disease, or leprosy. Snuff takers perforation is seen in tobacco or cocaine addiction where it is being snuffed. Chromium perforation is common in chrome workers due to acid fumes, and pink ulcer perforation is due to picking off of an ulcerated area. Nasal cavity, differential diagnosis that it could be narrow due to septal deviation or hypertrophy of the turbinates or polyp or growth. It could be wide due to atropic rhinitis. Discharge could be associated with mucoid, mucopurulent, purulent, or blood. And nasal mucosa is normally pink, and it is congested in case of common cold, rhinitis medicamentosa, pale in allergic rhinitis, and dry and crusting is seen in atropic rhinitis. It is normally seen as a concave tongue. So floor of the nose defect could be associated with cleft palate or fistula, swelling like dental cyst, or neoplasms like hemangioma, or granulations like foreign body or osteitis. Similarly, turbinates are enlarged and swollen in hypertrophic rhinitis, vasomotor rhinitis. They are small and rudimentary in atropic rhinitis, and it is congested in inflammation and pale in allergy. Inferior and middle meatises could be associated with discharge and polyps in the middle meatus, like due to infection of maxillary, frontal, or anterior ethmoidal sinuses, and between the middle turbinate and the septum, that is the posterior group of ethmoid sinuses. On examination of oral cavity, mouth opening was found to be adequate. Lips, gums, GV sulcus, teeth, floor of the mouth, buccal mucosa, hard palate, and anterior two-thirds of tongue were all found to be normal. In terms of examination of oropharynx, bilateral base of tongue, uvula, soft palate, bilateral anterior pillar, bilateral posterior pillar, bilateral tonsils, and posterior pharyngeal wall were all found to be normal. And in terms of larynx, Bilateral vocal cords were found to be mobile and laryngeal capitus was present. In terms of neck, no swelling and cervical lymphadenopathy was seen, and on ear, bilateral tympanic membrane were found to be intact. Now, on examination of ear, pre-auricular, post-auricular region, external auditory canal, and tympanic membrane were found to be normal on both right and the left side. Rene test was found positive on both right and the left side. Weber was lateralized to both sides equally, and ABC test was positive on both right and the left side. And in seventh cranial nerve examination was found to be normal on both right and the left side. So my provisional diagnosis with epistaxis. Investigations that were done were diagnostic nasal endoscopy. X-ray PNS was done in Waters view. Routine hematological and biochemical investigations were done. Importance of hemoglobin in my case is that it could be reduced in epistaxis, malignancy, and chronic inflammatory swellings. Total and differential WBC count was increased in inflammatory swellings. Platelet count could be reduced in epistaxis, or ESR is normally raised in malignancy and chronic inflammatory swellings. This being a COVID era, we are doing COVID-19 RT-PCR and HRCT tests for the safety of both patient and the doctors. And finally, chest X-ray was done in PA view. So management of an epistaxis patient includes home care, counseling, reassurance, position of the patient, that is sitting with the backrest, monitoring of vital parameters, intermittent oxygen, antibiotics are given in case of infection, and investigations and treatment of the cause is important. And anterior nasal packing is done, or nasal cautery and surgical treatment are the various parameters that covers depending on the cause. So general measures in epistaxis are that we make the patient sit up with backrest and record any blood loss taking place through spitting or vomiting. Mild sedation should be given. Checking pulse, BP, and respiration is important. Maintenance of the hemodynamics is important, that is blood transfusion may be required in some cases. Antibiotics can be given to prevent sinusitis if back is to be kept beyond 24 hours. Intermittent oxygen may be required in patients with bilateral packs because of increased pulmonary resistance from nasopharynx reflex. Investigation and treatment for any underlying local or general cause is important. Home care in terms of epistaxis patient covers two things: prevention and treatment. Prevention is like avoid frequent cleaning of nose with finger, maintain proper nasal hydration with saline or gels, and increase ambient humidity with a bedroom humidifier. Treatment consists of pinching the nose with thumb and index finger for about 5 minutes. Place a small piece of cotton soaked in decongested nasal drops. Lean back no further than 45 degrees. The Trotter's method is done and cold compresses are given over the nose. In Trotter's method, patient is made to sit, leaning a little forward, breathing quietly from the mouth, and apply cold compression. This causes vasoconstriction. In cauterization, it is useful in anterior epistaxis when bleeding site is localized. Topical anesthesia is used. Bleeding point cauterized with either silver nitrate or coagulate with electrocautery. This is the diagrammatic representation of anterior nasal packing. It is done if localized bleeding is present, and bleeding, if sometimes the bleeding point is we are not able to localize. In this, we use a ribbon gauze soaked with liquid paraffin, 1 meter gauze, 2.5 centimeter gauze in adult, and 12 millimeter gauze in children. It can be done with vertical layer and horizontal layer. Can be removed with 24 hours and can be kept up to 2 to 3 days. Systemic antibiotics should be given to prevent sinus infection and toxic shock syndrome. In posterior nasal packing, this is a diagrammatic representation, and it can be carried out through different instrumentation like gauze, Foley's catheterization, or nasal balloon. This is a diagrammatic representation of Merocil used for nasal packing. So most common non-absorbable nasal packing material it is used. It is compressed, dehydrated sponge composed of hydroxylated polyvinyl acetate that can increase in size within the nasal cavity and compress a bleeding vessel through rehydration with normal saline. So that it is how it is done. And for nasal cautery, we can use chemical cautery. It is done with a bead of silver nitrate. It is useful. And electrocauterization includes monopolar, bipolar, or suction cautery. Suction cautery is done in cases of failure and severe bleeding, or it could cover endoscopic nasal cautery. So endoscopic cauterization is done under topical or general anesthesia. Bleeding point is localized with rigid endoscopy and cauterized. Procedure is effective with less morbidity and decreased stay in the hospital. With profuse bleeding, it is very difficult to localize, so this procedure can't be carried out. Now, surgical treatment includes the elevation of mucopericondyal flap from the nasal septum. This results in fibrosis and constriction of blood vessels. Submucous resection operation with removal of septal spur also achieves the same result. Or arterial embolization can be done, or arterial ligation can be done. In this, external carotid artery ligation is done above origin of superior thyroid artery. Maxillary artery could be ligated from in transcentral or endoscopic approaches, and ethmoidal artery is ligated above the level of middle turbinate. And the other procedure is endoscopic ligation of sphenopalatine artery. So elevation of mucopericondyal flap and submucous reception operation is done in cases for persistent or recurrent bleeds from septum or elevation of mucopericondyal flap. This helps to cause fibrosis and constrict blood vessels. Now, instruments that we use are, this is the diagram of nasal endoscopic suction cautery. Now, coming to question and answers. So, what are the features of frog face deformity asked by Dr. Shreya? The answer is that it could includes broadening of the nasal bridge, proptosis, swelling of the cheek, involvement of second, third, fourth, and fifth cranial nerves, and diplopia and visual field defects. So the next question is, what is the classification of epistaxis asked by Dr. Almas? It covers primary factor when there is no proven factor and secondary when there is a proven causal factor. In childhood, when the age is less than 16 years of age, and in adults when the age is more than 16 years of age. And it could also be classified under anterior and posterior, like in anterior, when the bleeding point is anterior to piriform aperture, and in posterior, when the bleeding point is posterior to piriform aperture. So the next question is, what are the various materials used for anterior nasal packing, asked by Dr. Praveen? The materials are ribbon gauze, Meroseal, gel foam, or oxidized cellulose. So the next question is, what is the most common cause of bleeding from nose in elderly and in children, asked by Dr. Bhargavi? In children, the most common cause is repeated fingernail trauma, and in elderly, it is hypertension and atherosclerotic changes. So the next question is, what is the Fish staging classification of juvenile nasopharyngeal angiofibroma, asked by Dr. Monica? So the first stage is when the tumor is limited to nasal cavity. The second stage is tumor extending to pterygopalatine fossa or maxillary sphenoid or ethmoid sinuses. The third A stage includes tumor extending to orbit or infratemporal fossa without intracranial involvement. Third B stages covers the stage 3rd A with extradural intracranial involvement. Stage 4th A involves intradural extension without the involvement of cavernous sinus, optic chiasma, or pituitary fossa. And stage 4B includes involvement of cavernous sinus, optic chiasma, or pituitary fossa. So what is the dangerous area of the nose, asked by Dr. Biman? It is the olfactory area of the nose. So olfactory nerve terminals have pia arachnoid sheath while passing through the cribriform plate. So the subarachnoid space is in the continuation with nerve terminals. So what are the most common sites involved in anterior and posterior epistaxis, asked by Dr. Arushi? In anterior, it is the Little's area and anterior part of lateral nasal wall, and in posterior, it is the posterior superior part of nasal cavity. So what is Lederman's classification, asked by Dr. Nivika? He described two horizontal lines, one from the floor of the orbit and other from the floor of the antrum, that is suprastructure, mesostructure, and infrastructure, and two vertical lines drawn from the inner canthus, dividing nose and sinuses into 9 segments. So suprastructure involves ethmoid, sphenoid, and frontal sinus and olfactory area of the nose. Mesostructure involves maxillary sinus and respiratory area of the nose, and infrastructure involves alveolar processes. So what is the most common artery involved in epistaxis, asked by Dr. Nishan? That is the anterior ethmoidal artery. Thank you.